Matalia, and I'm going to be talking to you on neuro-ophthalmic visual fields, basic and interpretation. So what is the role of fields in neuro-ophthalmology? It's a specific anatomy of the visual pathway, and this allows topographic localization of the visual field defects. Now, initially, we were usually using it, we were able to check these by using the Goldman kinetic perimetry. But lately, it's the automated static perimetry that we are using, and I'm going to be primarily talking on the same. So let us just understand the visual pathway before we go into interpretation. Now, as you can see, this is a right visual field and the left visual field, and this is represented in our retina. But what is important is that it is inverted and reversed images that happen, which means that if it's a nasal field, that is represented in the temporal retina, and the temporal field projects into the nasal retina, which happens in both the eyes. From here, the axons rise and develop into the optic nerve, which read the chiasma and form the optic tracts. Now, as you will note here, that the temporal retinal fibers move along and form from the left side, from the left tract. Similarly, the right temporal retina will move along the right optic nerve and do not decussate at the chiasma and form the left optic tract. So what happens is the nasal retinal fibers are the ones that cross at the chiasma, and this is very important because that is some extent related to the findings that come in the neurological visual fields. Now these axons finally synapse at the lateral geniculate nucleus, and from here arise the optic radiations, and these radiations eventually reach the primary visual cortex. So what is interesting is any damage to any of these structures as mentioned here from 1 to 8 will show characteristic visual field defects as is seen here. And what I am going to do today is help you reach this diagnosis. So note, what we will be having in this presentation is looking at the visual field and trying to reach what the problem neurologically could be. So how do you interpret? Now, before going to interpretation, I'm going to be showing you a couple of fields, and what you need to know is we are assuming that these fields are perfectly reliable. So before you go on interpretation, always note that the reliability status, like any other glaucoma field test, also should be checked. You should be ensuring that the fields are absolutely reliable, the gaze tracking is good, there is no learning curve involved, and then you go on interpretation. The other thing is that in neuro-ophthalmological fields, we look at the grayscale and not necessarily pattern deviation. Also, we do look at it, but we look at grayscale, which is not looked at by our glaucoma colleagues. So how do you interpret? First, you keep the right side field on your right and the left side field on the left, which can be directly read looking at
Jyoti, your audio,
which I believe is very easy. Yeah, Satya?
Yeah, now it is okay.
You were not able to hear the previous slide. Should I repeat?
Yes.
Right. So what I'm talking about interpretation of visual fields is provided you are knowing that the fields are highly reliable. You cannot do an interpretation if there is any problem with reliability parameters like in glaucoma field. So you have to look at it. You have to ensure gaze tracking is good. You also have to see there's no learning curve, and then you go about interpreting. Unlike glaucoma fields, we look at the grayscale. And how do you do it? You look at the position of the blind spot and always keep the right-sided field on your right and left-sided on left when you're doing interpretation, because we are going to be looking at both the eyes. Now, there's a power of 6, which I believe that we should follow in neurological fields. There are 6 questions that we should ask when you are evaluating these fields. First, is the field loss unilateral or bilateral? Because if it is unilateral, it's anterior to the chiasma, unlike bilateral. So let's go back to our representation, in which you will notice that if the field defect is only in one eye, the lesion is anterior to the chiasma. But in these cases where there is bilateral visual field defect, we are looking at a prechiasmal, chiasmal, or a post-chiasmal lesion. Then the second important question, does the defect represent the respect to the vertical meridian? Because if it does, it's a chiasmal or posterior lesion. Like for example, look at these various visual field defects. They are representing the vertical meridian. And if you note that from 3 to 8, wherever there's a chiasmal or posterior chiasmal lesion, you will find the same representation happening. But in those which are anterior, you will see one eye is completely involved. So they are not respecting the vertical meridian. Then question 3, what is the pattern? You could have a central scotoma, a centrocecal scotoma, where the central scotoma is mixing with the blind spot, a paracentral scotoma, You can have an altitudinal defect, which we know is mostly commonly related to either an optic nerve problem like ischemia or optic neuritis. This respects the horizontal meridian. An arcuate defect, which we have commonly seen in glaucoma patients. And then what is more common in neurological fields is hemianopia, the field that involves the defect that involves the field either to the left or right of the point of fixation. This does not cross the vertical meridian. And a specialized hemianopia is a quadrant anopia that lies between the vertical and the horizontal midlines. So now comes to the fourth question. Is the field bilateral? If it is bilateral, then we should find out whether it's homonymous. So what do you mean by homonymous? As you can see, it is the right side or temporal field of the right eye and the nasal field of the left eye. So this is what a homonymous field is. And if this is seen, it's mostly a posterior chiasmal lesion. And once you know which is homonymous bilateral, you should look which side of the field is affected. Like for here, you will see classical homonymous field defects. And here you will see the posterior chiasmal involvement from 4 to 8. So in this case, it's left-sided. So because all the defects are on left side, when you have a left-sided defect in neurological fields, you should expect a right problem on the opposite side. As you can see here, it's a right tract involvement and right tract and radiations. There's another interesting feature. What you see is number 5. And you can see this is basically the inferior radiations. These inferior radiations are causing the classical defect, which is superior. And this, on the other hand, are the inferior quadrant anopia or inferior incongruous hemianopia, where you see the defect in number 7, which are basically the superior radiations. So let us understand what this is. These are contralateral incongruous homonymous hemianopic defects, which are involving either a temporal lobe or a parietal lobe. Now, the temporal lobe, which is this classical appearance, is a pie in the pie, which is denser superiorly. And this will have the characteristic neurological signs. Parietal lobe, on the other hand, is a pie on the floor, which are denser inferiorly, and you get the characteristic parietal lobe signs, and other features are seen. Now, what we've been talking is about homonymous hemianopia, but there is also something called heteronymous hemianopia. Now, this is what we discuss as homonymous, but look where there is a same-sided involvement, like left side in this case. But in heteronymous hemianopia, we are finding the same fields. So here, if you see, both the temporal fields are gone, and this patient has a bitemporal hemianopia. And when you see a defect like this, it has to be at the chiasma. If you remember, the nasal retinal fibers were crossing over here, and that's the reason why you get this defect. And when you get it, when you have a classical lesion like a chiasmal tumor, as seen in this case. Now, coming to the last important question, is the defect congruous? Because if it is congruous, it's more and more posterior, which means most probably an occipital lesion. So what do you mean by congruous and incongruous? When the defect in one eye does not resemble that of the other eye in shape, extent, and laterality, it's incongruous. And when it does, it's a congruous lesion, which you see in these two fields, which is classically an occipital lobe lesion. Like in this case, you can have 4 types of occipital lobe lesions. One, a classical homonymous hemianopia, which is highly congruous, a macular involvement only, a basic homonymous hemianopia with macular sparing because there's a dual supply coming to the occipital lobe, and finally a temporal crescent. So then how do you write this interpretation? First, which side of the defect, right or left? Whether it's quadrant anopia, then it's superior or inferior. If it's hemianopia, then it's complete or incomplete. And if incomplete, whether it's denser superiorly or inferiorly, congruous or incongruous, macular split present or not, and central or not. So let us remember that this is not always the case. There are exceptions to the rule. And one is a bilateral altitudinal congruous lesion, which is an occipital lobe. Like for example, a congruous superior altitudinal defect as seen here has bilateral infarcts of the inferior occipital lobe. You could also have bilateral peripheral constrictions. It is commonly seen in intracranial hypertension on occipital lesions. Like here, if you notice, there's a peripheral constriction because of anterior calcarine sulcus involvement. So there are going to be exceptions everywhere. Let us move with some interesting cases. And as I go on, I would like all the participants to try to apply the same questions and see if they can reach the same diagnosis. Again, 6 important steps. Is the field loss unilateral or bilateral? What is the pattern? Does it respect the vertical meridian? If bilateral, is the defect homonymous? And which side it is involved? And finally, the congruosity. So let's look at this. This is case 1. We know this is bilateral. respecting the vertical meridian, classical pattern being quadrant anopia. So basically we have a left inferior quadrant anopia, that's pie in the floor. And when you have a lesion like this, which is the pie in the floor, we have to think of the opposite. So right parietal lobe lesion. So let's go to another interesting case. Look at this. It's unilateral, bilateral. Yes, unilateral. So the lesion is going to be anterior to the chiasma. And then obviously we have to look more carefully at the optic nerve. Note that the vision in the left eye is less. So this is a classical pallid disc edema. Now note here that you would not be getting the field before seeing it. This is just a way of interpretation. But remember always, whatever fields I'm showing, you need to understand it has to be clinically correlated either with the MRI or the optic nerve or an ophthalmological finding to reach the diagnosis. So this was a classical case of anterior ischemic optic neuropathy. Let's go to case 3. Again, we see the vision in one eye is less, but classical field defects, temporal fields of both eye are affected. So this is a bitemporal hemianopia, and only one time when that can happen is position 3, which I mentioned to you when you're looking at a chiasmal lesion. But before that, take a look at the optic nerves. You must have missed something there. What we noticed that the patient had temporal pallor. So we know there's definite compression happening of the optic nerve, and the diagnosis was a pituitary adenoma. Case number 4, this was again bilateral, respecting the vertical meridian, involving one area. So basically a superior right quadrant anopia. Again, we are looking at a right pie in the sky. So look into the temporal lobe and we find that it could be something in the left temporal lobe. And when we did the MRI, what was interesting is these multiple blackish spots which are seen, which are CSF spaces. And this is called as the Werkow-Robin spaces. And we were the first to publish it, as these spaces producing visual field defects is previously never reported in Neurology India. Then case 5, as you can see here, there are central scotomas happening in both eyes. But remember, they are not respecting the vertical meridian. That means we have to go more anteriorly, look at the optic nerves, look at the retina. And when you look carefully, you are seeing temporal pallor in both the eyes and also macular lesions. And FFA will give you the diagnosis. This is bullseye maculopathy. And this is how will you get on the visual fields. So what are the indications when you should ask for this visual fields? One, diagnostically unexplained visual loss, following trauma, very important. Patients coming following accidents, you should always do the visual field for the other good eye. Like this patient had lost vision in one eye, but had 6/6 vision in the other eye. What we know is the chiasmal injury, because if you miss to do it, you will never realize that he has issues because he's already one-eyed. The other problem is that the patient will come later on and they're assuming he has a temporal hemianopia, may want to be investigated unnecessarily. Then any case of optic neuropathy, neurologically, like for intracranial tumors, following head injuries, in presence of papilledema, before and after neurosurgery, and follow-up when important, like in case of resolution, progression, and recurrence of disease that affect the visual pathways, including the optic nerve. So let's look at how do we go about. So if you have a visual field and the defect is unilateral, then we are looking at the optic nerve problem where you can either have a central scotoma, centrocecal, or a paracentral, altitudinal scotoma, which we are looking at an ischemic optic neuropathy, arcuate, where we are looking at a problem cause being glaucoma, peripheral constriction like idiopathic intracranial hypertension, and sometimes even you have an enlarged blind spot. You could have a prechiasmal lesion where it's a junctional scotoma, monocular scotoma of Trachwire. Like for example, if you notice here, this is position 2, which is prechiasmal, and what you find is one eye affected completely, but the other eye is only in the periphery, for which you should specifically do more of the full field to pick up these scotomas. Bilateral visual field defects could be heteronymous or homonymous. Heteronymous, you know, they are bitemporal hemianopias. If they are denser superiorly, then we are looking at a pituitary adenoma. If it's denser inferiorly, it's a craniopharyngioma. This, if it comes completely, it's difficult to make out. But in the initial phases, you will have these kind of presentations. Then homonymous, where we are looking at superior defects. This could be, as I mentioned, temporal lobe lesions as a pie in the sky. Inferior defects, which are parietal lobe lesions, which is a pie in the floor. And more congruous, we are looking at lesions more posteriorly, that is in the occipital lesion. So what test do we actually order? Central lesions, we look for 10-2, 24-2, and 30-2. Some people do 24-2, especially in these cases where neurologically you are not sure the patient will be able to sit, so less points to check. Peripheral fields, lesions, you need to do the full field 120, like for constrictions, peripheral constrictions, or junctional scotomas. Drugs toxicity 10-2, a red target on white background also can be used. And you can, for functional disability, you can do binocular test as well. So these are the various tests when you should order. So let me end by showing you an actual case scenario, how the power of visual field helps in reaching a diagnosis. This is case 1, a 36-year-old gentleman who came with a known case of tuberculosis on treatment. There was history of seizures and was also being treated by the neurologist. There was hypertension under medication. He was referred to an ophthalmologist for blurring of vision in both eyes. If you notice, the vision is absolutely normal, color vision is normal, pupils are also fine, the fundus is perfectly okay. Similarly, there's another case who came with a 29-year-old gentleman wearing spectacles since 5 years. There was blurring of vision in one eye since a month. The vision was also perfectly fine. The discs also look okay and the pressure was all normal. So the important thing what we should notice is a patient comes to you like this, where there is a problem, but you are not actually able to figure out what it is. Before ordering major tests, all you need to do is a visual field. So first, the patient is always right. If he's saying there's a blurring, try to pick it out and do a visual field testing. That's the simplest thing to do. So we did a visual field testing for both the patients. So let's look at the first case who had a bilateral problem. If you notice, these are the visual field defects which he has. Let's go to case 2, similar defect, but now in one eye. So I just want to know how we will be applying the same 6 questions to get to a diagnosis. So is the field loss unilateral or bilateral? Yes, in one eye, unilateral. So we are looking at a problem anterior to the chiasma, and bilateral for the case 1. Second, does the defect respect the vertical? Hello, am I audible?
Yes, you're audible.
Yeah. So the next question, does the defect respect the vertical meridian? Yes, it does in both cases. And what is the pattern? So it is central. So a similar pattern, but has a representation, one unilateral and one bilateral. So coming to our case, the case 1 will definitely have a posterior chiasmal lesion because it's bilateral respecting the vertical meridian. This being only unilateral, we are looking at an anterior chiasmal lesion and having the same pattern as central. So now coming to the next question, bilateral, is the defect homonymous? Yes. And which side of the defect it is? And the defect is congruous. So yes, what we are getting it for the more posterior lesions, that the case 1 which we have is classically having the bilateral, homonymous, side involvement and congruosity. So this all fits into case 1. So our central posterior chiasmal lesion of case 1 is actually a left homonymous congruous defect. And to define it, it's a left superior congruous quadrant enopia. And when we are looking at a central defect,
Your voice is gone.
now that we know that both the cases have a central lesion, one is unilateral, one is bilateral, then we come to the important question that in the case 1, which is bilateral, it's homonymous, which side it is affected to one side, and it is congruous, which all fits in case 1. We are basically looking at a left homonymous congruous defect. And when we are looking at a left homonymous congruous defect, is the left superior congruous quadrant enopia. As I showed you earlier in the occipital lesions, that you could actually have a central lesion, we should think in terms of the occipital lobe, and hence this patient had an occipital lesion. So let me describe to you what you get, the representation of the occipital lobe. Here you have the calcarine fissure, the superior calcarine cortex, the inferior calcarine cortex, and the tip of the occipital lobe. So if you notice the tip of the occipital lobe, the representation is right at the central, and that's why you can have a central defect. So what this patient with the left superior congruous central quadrant enopia had actually a problem, tip of the occipital lobe, and as you have the opposite involvement, this patient had a right inferior calcarine cortex. So then once we realized this, when we got the MRI rechecked, we realized that this patient had multiple ring enhancing lesions in the right occipital lobe with perilesional edema, and those infective, likely to be tubercular. And this patient was then diagnosed as CNS TB. Then going on to a case 2, where we had a central anterior chiasmal lesion involving only in one eye. What we realize is because it's an anterior chiasmal, we have to go back and re-explore the optic nerve. So this eye, which had a left eye superonasal central defect, we have to look at the fundus for anything which is inferotemporal. And then if you look carefully, you will notice that there is basically a nerve fiber layer defect which is there. So this eye had an inferotemporal nerve fiber layer defect suggestive of a glaucoma. And since this patient had normal IOPs, this patient was probably a NTG. So I want to end by saying that when you have a visual field, whenever you suspect the patient is not able to see, do a visual field. If you have a visual field, keep it appropriately. Use these 6 questions to reach a diagnosis. But remember, the reliability and the parameters of the visual field should be normal. The patient should be able to really have done the good test, look at the grayscale, and very, very important, never forget to clinically correlate either with your fundus findings or with your neurological test. Thank you. Any questions?
Just a second. Okay, any
I
questions?
have a question.
Go ahead.
Yes, Prashant.
For peripheral lesions,
Samir and Chutney man.
full field. So you do a full field 120-2.
The others can mute. The person who's asking question can.
So for peripheral can you hear me? Hello?
So your question is?
For peripheral fields, you said we need to do a full field. So that's the 120-2, is it?
Yes, right. So I mean, peripheral fields are something which are, you're looking at junctional scotomas which are extremely in periphery, or you want to look at real constriction, early constrictions in patients where it's like in papilledema, because by the time they come and encroach your 30-2, it is actually too late, and then you may have to go intervene. So early constriction, junctional scotomas, you may need to check by looking at the peripheral fields, which is 120-2.
Thank you.
So I guess somebody's asked question, how do you differentiate papilledema and papillitis? So when it comes to field tests, it is different. So clinically for papilledema and papillitis, it is looking at the optic nerve itself will tell you whether the diagnosis is papilledema, papillitis. Now the effect and the pressure of that, say papilledema on the optic nerve will give you a different kind of visual field. Classical appearance of a papillitis would be under an altitudinal defect. So in those cases, you will immediately see a patient who has a swollen disc, which is bilateral, is classically an papilledema. Unilateral cases are the ones which have classical papillitis. In those cases, you will have an immediate visual field defect. For papilledema, the visual field defect suspected takes a lot of time. And that can vary completely. It starts with first having an enlargement of blind spot. You could also have the first test, that is inferior step deformity that comes in, and then eventually a complete constriction that develops. But for a papillitis, within a few days, you'll get a defect, like most commonly an altitudinal defect that comes in. But it's basically the clinical scenario which will decide what the diagnosis is. And on that basis, you will then advise what tests. So in a classical case of papillitis, you may not really want to do a visual field. The clinical diagnosis itself will help. And you will get a classical relative pupillary afferent defect in that eye. So in a case of suspected toxic optic neuropathy, this is Manish Bapaye. Sorry. That is Harsha Pagat. In case of suspected toxic optic neuropathy with poor vision, what should be the investigation of choice? So in that case, basically, we would not be able to go too early. You should take a very, very good history, find out the history of what sort of treatment, like most commonly we see ethambutol toxicity. In those cases, a color vision is most important because you may not be having in a condition to do a visual field. So do the color vision. Then what is the protocol for visual field suggest to do for suspected lesions? So basically, if you're asking for a visual field in cases with neurological lesions, you need to do a normal 30-2. If the patient you feel is not suitable to sit, you can do a 24-2. If you're looking for any specific lesion, like as previously mentioned, any toxic optic neuropathy, do a 10-2.
Madam.
So yeah, in the previous, yes.
Yeah, so this is Manish Bapaye. I just wanted to ask you, in which patients would you suggest full field 120?
Yeah, so as I mentioned, I would do it if I'm suspecting like a pre-chiasmal tumor or a spread there. Patient is complaining of decreased vision, and I'm getting one field involved. The other eye, if I want to pick up a junctional scotoma, then I would do. Okay. But routinely, we don't do that. If I want to look at some peripheral constriction areas for like early cases of papilledema, to look at early constrictions, I would do it. Then Dr. Gurucharan Singh is mentioning in last case, should not the field defect be continuous with the blind spot? Yes, so it could be, but it's not always that specific. You do not always get same kind of appearance as you would expect. So it is very surprising to know that just getting a central scotoma, that is only that is also restricting to the vertical and horizontal meridian, is very, very unusual. But you get, so when you get a situation like that, you need to also think out of the box. And in this case, as you saw, was basically an NTG. And in NTG, then you have to look for other causes, get a cardiology workup done, because right now it's basically NTG is known to be like an ischemia to the optic nerve, not a classical glaucoma. Now they're considering it in terms of an optic neuropathy. So you need to anyway investigate from those lines. For toxic optic neuropathy, 24-2 followed by 10-2 if a small suspicion. So Dr. Revati is asking for toxic optic neuropathies, a 24-2 followed by 10-2 if a small suspicion lesion is seen. Yes, definitely. Suppose if I would have done in a patient like this, if I would have done a 30-2 and realized that no, I'm not actually able to see any defect, then I will go back to a 10-2. Many a time there are situations where the patient is saying that he cannot see and you may not pick it up on a 30-2. So those cases you have to go in for a 10-2. Dr. Sonali Gupta, what target size do you use for Humphreys fields in eyes with poor vision if we do not have if we don't have Goldman fields available at our center? So nowadays a lot of people are doing Humphreys only. So we basically see on the basis of vision. If the vision is less than 636 or less than 660, you can try size 5. That is what you can try, but in that you will not get a pattern deviation chart. All you anyway want to know is there any gross involvement? So many a times it's just looking at the grayscale, you can figure out, oh, this is what is anticipated. Maybe the patient is not very, very reliable. The gaze tracking is not good, but at least a fair and a faint idea about what we are dealing with. Then Dr. Revati again. If a clear centrocecal scotoma is seen in 24-2, then 10-2 is not needed. Yeah, so if you see any defect which is there on a 24-2, you don't need to go in for a 10-2 unless you are looking for something specific. And when you are seeing a defect on any of the visual fields, you need to correlate it clinically and see that can you really explain why this defect is there. So once you have a defect at any time, you can. But sometimes if you want to reconfirm, then you can go ahead and do a retest. But as I said, there are very important parameters which cannot be missed. You have to look, it's not the learning curve. Look at the reliability parameters. That is a false negative, false positive. The fixation. You have to look at gaze tracking. Many a times, a lot of centers do visual fields without looking at gaze tracking. And sometimes the gaze tracking is so bad. So it's always important that gaze tracking should be on and you have to look at it when you are trying to evaluate your visual fields. For HCQS, what is the protocol? So usually for HCQS, you can do field tests, but that's in a later bit. Multifocal ERGs are better to be done initially to pick up any problem because we're looking at a macular pathology in these cases. So by the time the damages come, it may be too late. I think a possibility of doing an OCT also may help. That is to look at the ganglion cell complex to see if we can pick up any derangements happening where the patient is on HCQS. Investigation of choice in AION. So investigation basically in AION, if you're looking at an anterior ischemic optic neuropathy, we are looking at it's basically the optic neuropathy where you are going to pick up and classically a feature of the optic nerve, like you will have a swollen disc, you will have presence of hemorrhages, a classical RAPD. In those cases, visual field is just done to see and sometimes helps to, okay, in those cases, because of the blood supply issues, you'll get a classical argitudinal defect. But that is not the treatment of choice. Investigation, what you do is to rule out any ischemic cause for the AION, which means you have to do the blood parameters, rule out, get a good history to rule out the hypertension, diabetes, any other causes, which can be the cause for the patient having an ischemia that develops. Nowadays, we also look for sleep apnea studies, any medication that he is taking, most commonly any hypotensive medicine in the night, which can be the cause for this patient developing an AION. So it's basically a good history, including what medication is taking, and do an entire workup for ischemic risk factors. And visual fields are just a parameter that can help to tell you whether this actual, what sort of defect is getting in this particular AION. But remember, for any optic neuropathy, whether it's papillitis, anterior ischemic optic neuropathy, or a retrobulbar optic neuropathy, you always have to do a good swinging flashlight test, because when it's unilateral, a relative afferent pupillary defect will tell you that it's an optic nerve involved. In a patient who has papilledema, which is bilateral, you will never get an RAPD unless there is a superimposed problem in one of the optic nerves. So to differentiate any of these optic neuropathies, a very good pupillary examination has to be done, where you make the patient look at distance, because you don't want him to look into your light. That will stimulate accommodation and will do a very good swinging flashlight test. It is possible to get 120-degree field in Humphrey. Yes, we have done. Humphrey does have 120-degree field. But as I said, you would normally routinely not do it. A neuro-ophthalmologist who routinely sees patients may want to do it. If you are suspecting that this patient has a tumor at the chiasma, looking at all the features, but you're not able to pick it up on your fields and you are suspecting a junctional scotoma, then you can do it. But it's definitely, it is there in the program of Humphrey. As I also mentioned, there are these binocular field tests also, which we do for functional disability, and that is also available. So sometimes if those who have their, the Humphreys at their place, you should go through the manual and then you realize there are so many options and so many things you can do. Like for ethambutol, you can do a red target on a white background. That can be done in early stages if you really want to pick up. 120. Till what extent of low visual field you advise? I prefer to advise visual fields up to 6/60. I tried using size 3, but if I'm finding it's difficult and I definitely want to get a visual field information, then I usually advise for size 5. So when do you say the blind spot is enlarged by seeing the visual field? So normally, as you have seen in the previous, when the blind spot is increased more than 4 degrees all around. However, many a times you should figure out that sometimes the patient is not properly centering or sitting properly, and you may have a displaced visual field. Displaced blind spot. So be in a position to differentiate whether it's a displaced blind spot or it's really enlarged. And again, you need to really correlate with the finding. So if you have an enlarged, and you would get an enlargement of blind spot in papilledema only in very, very chronic cases, not in the early stages. You really don't get it in the early stages. But if you get it in the later half, where you later chronicity of papilledema, you will get those cases, you'll see enlarged blind spot. So in those cases, you will be able to say that it's enlarged. The other thing what you need to figure out in papilledema, the first thing that comes up is an inferonasal step, and that is very, very important. So if you find your patient with papilledema developing an inferonasal step, you need to monitor them more regularly, say every 4 to 6 weeks, because if this inferonasal step starts increasing, this patient will eventually land up developing complete constriction if the papilledema treatment is not done to resolve the edema. So that's the first step first sign that you see in papilledema, and not the enlargement of blind spot. Please explain. Please explain Humphrey's visual field procedure, functional visual loss.